We're excited to announce that our podcast, The Table with Renee Da Silva, is evolving. We're introducing 3 new streams of content on this podcast, designed for Health System CXOs and hosted by the Health Management Academy's subject matter experts for health system nurse executives, health equity officers, and strategy executives. With this change, we'll be activating health system leaders towards outcomes and scalable solutions you can implement now.
Hello, and welcome to the Health System CXO podcast, featuring 3 streams of content designed for health system nurse executives, health equity officers, and strategy executives. I'm Jackie Kimmell, Senior Director of Member Insights at the Health Management Academy, and Strategy Executives host, sharing the latest market trends and essential insights happening across healthcare so that you can chart a strategic path forward for your health system and move quickly and expertly in the right direction. Hi everyone, Jackie Kimmell here, and excited to join you all again for another podcast focused on Medicare Advantage. So if you'll remember, last time we talked about Medicare Advantage, we really walked through the market landscape at a high level. We tried to understand why so many patients have signed up for Medicare Advantage and why Medicare Advantage is becoming a major pain point for so many health system executives. If you'll remember, we really focused on yield, the expected amount that executives want to get and expect to get from Medicare Advantage contracts that has been declining to about 85% or below on average from their MA contracts, and how that's really a challenge for so many health systems today. What I want to do in this episode is continue this conversation by sharing a little bit more behind the scenes of what I heard when I spoke about this topic with executives from across the country and across different types of C-suite roles this spring and this summer. And I'll share where there was agreement and disagreement among executives around some of these key strategic moves. After that, I'm going to walk just a little bit through what we've seen in the last few months from a payer standpoint and start to try and give you my crystal ball of what to expect in the next few years when it comes to the MA landscape. It's a lot, so let's go ahead and dive in. So first of all, I think one of the themes that came out most strongly from all of the speaking I did on this topic in the last few months is an acknowledgement amongst most health system executives that MA contract management must be more strategic and active amongst leading health systems. And I will explain why. So we just mentioned again yield. Yield has been declining below 85% on average, and this is having a pretty deleterious impact on health systems. What we saw in a recent survey of chief financial officers was that 61% strongly agreed that MA plans have negatively impacted the financial sustainability of their health system in 2024 and that they will continue to do so in the future. Only 16% of CFOs in our sample said that MA has been a positive trend for the financial sustainability of their health system. So what is clear from that statistic is that obviously many CFOs are wondering how the system is going to be able to weather the financial storm of the growth of MA and that declining yield. And of course, part and parcel with that is the fact that getting timely payments from payers has been an increasing pain point. Almost every executive I talked to this past spring and summer agreed with that from systems across the country. And many noted that in addition to denials and prior auths, they are seeing a huge increase in the number of audits that are coming through from MA payers, with some systems seeing almost a 3x growth in terms of the number of audits that are happening specifically for MA patients. And all of that is leading to what I'm sure you've seen if you scroll through Becker's emails or Modern Healthcare, that there are a growing number of disputes now reaching kind of last minute phases in terms of the threat of contract terminations. We saw that in Q2 2024, there were about 20 health system reimbursement disputes with payers that made the news, and actually 15 of those 20 were about Medicare Advantage. So that is the major flashpoint, with about 30% of all of those disputes not reaching a timely agreement, with the health system ending up terming the contract. So when I actually, asked health system executives, both from the leading health system, so above $2 billion in revenue, as well as the regional health system, so a little less than $2 billion in revenue, markets, what they expected in terms of termination of contracts, many of them are concerned that that is going to continue and grow even worse over the course of the next year or so. This is not the most scientific statistic because, it was due to a raise of hands. But what we found is that about 60% of leading health system executives and about 90% of regional health system executives were looking to terminate or considering terminating at least one major plan in the course of the next year. So I think you will expect, if you are that loyal reader of Becker's, that you are going to see many more of those contract terminations. What is kind of less, I would say, agreed upon across health system executives is how sticky those MA plan relationships are. That is to say, once we start to see more of these terminations, once we start to see more health systems going out of network, are patients going to be willing to leave their plan to stay loyal to the health system, or are they going to find another place for their care? And, this was an interesting question for me. There were some who felt very strongly that MA plan relationships are quite sticky, that patients are not really going to want to shift their plan. And many of them noted that, they are pretty slow to move over to, maybe move into Medicare fee-for-service or to find another plan where the health system is in-network. Others noted that MA plan relationships in their experience are not that sticky at all, and that patients are pretty willing to move over either to find a new source of care or to find a new plan if that system goes out of network. And so I think it's going to be really interesting to see kind of what the shifts in market share start to be like as we see more of those terminations come through. There's certainly anecdotes of what is happening. We talked to many health systems who saw that when their competitors went out of network, that they saw an increase in share for their own provider-sponsored health plan for other competitors in the market who they were still in network for, and for, even reports of patients wandering around their hospital campuses trying to suss out the new system, who had previously been, loyal to their competitors. So I think it will be interesting to see what shifts we see in terms of market share over the course of the next few years once more of these terminations come through, and how willing payers will be to play ball with agreeing to those last-minute terminations and last-minute agreements. When, it comes to these really growingly risky contract determinations. There was also some really interesting conversation, I think, in these last few months, where executives talked about ways to make the contracting process more effective. There was some interesting agreement and disagreement whether it's better for systems to couple the MA with their commercial contracts to get more leverage in negotiations, with many finding that it does give a lot more leverage simply because, payers feel more need to have the major system in network for commercial patients in order to, keep employers happy. And so having that greater leverage by coupling those negotiations is valuable. There were others that felt that really stalled the commercial negotiations and ended up leading to a decrease in overall reimbursement. There was also a lot of conversation about how long contracts should be signed for. So many, I think, felt that they were trying to go for shorter term contracts in order to allow for a greater threat of termination in the future, and in order to be really able to police payer behavior more around some of those key things like KPIs around claims denials, yield, prior auth rates, etc. And so I think most believed that they are going to be starting to sign shorter term contracts so that the threat of negotiation is always going to be on the table. And, really actively monitoring their portfolio to understand how each payer is performing on yield and on kind of those vital KPIs that I just mentioned. So those were some of the conversations that were happening around the contracting situation. There was also a number of interesting conversations around what can be done from a legal or legislative perspective. And this is a bit of a challenging one. So CMS passed a law last spring, basically, and that is spring of 2024, I should say, basically trying to set some firm deadlines on when prior auths should be turned around based on whether the care is urgent or non-urgent. And unfortunately, CMS really considers the issue fixed because they passed this. Unfortunately, almost every single health system executive I talked to basically said that that law was somewhat of a nothing burger because the timelines for turnaround are so long to the point that they're actually longer than most of what's happening right now and longer than patients need to be able to, actually avoid substantial delays in care and to be able to impact and actually drive down length of stay from a health system perspective. What that means, though, is that unfortunately CMS considers this issue fixed. Congress has tried to codify this in the wake of the Chevron decision, and it's kind of unlikely, most experts think, that there's going to be substantial federal action on prior authorization over the course of the next few years. What you see is that some payers are still concerned about this. So United, for instance, is trying to roll out a much broader gold carding program, maybe to get ahead of future regulatory action. But really others are kind of resting on their laurels around prior auth at a federal level. What we expect more is that there's going to be action on a statewide level. And so some of the most interesting conversations I heard were around how do you get state legislators to understand this incredibly complex topic around prior auth, claims denials, MA in general, and how do you get them to start to understand the health system perspective? I think the most effective solutions were systems that have been able to get the state legislator on board with imposing financial penalties for payers that don't pay their payments in a timely manner. So many of those are making them pay interest on the lift or, pay back payments on unpaid claims or overturned denials. And so many systems actually saw a pretty substantial, in one case, a 15% reduction in their denial rate about 18 months after working with their state legislator to start to impose some of those financial penalties on payers. There were also some, finally, very interesting conversations on what this meant for health systems' own provider-sponsored health plans. And so the long and short of this topic is that most provider-sponsored health plans in MA are subscale. The median size of these plans are 6,000 lives. It has been very hard for most health systems to grow their MA plans, and you see that 3 major health systems dropped their MA plans across 2023 and 2024 just because the break-even point has been increasing almost every year. We heard from one system that it used to be 10,000 lives, then became 15,000 lives, and now their actuaries are telling them 25,000 lives. But in general, we haven't seen most plans be profitable up until they're getting about 50, 80, 100,000 lives, and that number is increasing every single year. And so there's a lot of interesting conversation around, is the provider-sponsored health plan in MA actually a viable strategy? There are some systems that were basically trying to roll back growth of their plan, thinking that the landscape is so hard right now with version 28 and with all of these headwinds around utilization that they actually might slow down the growth of their plan. There were others that said, no, we're going to go full steam ahead simply because it gives us so much leverage in our provider negotiations to be able to say that we have a plan. Payers don't need to know how big it is, but even having a plan allows us to have greater leverage around the negotiations that we're having. And so there's a lot of interesting kind of disagreement across different types of constituencies around how much a provider-sponsored health plan makes sense. Where I think there was agreement is everyone wishes that this was a viable option because it allows them so many ways to align incentives. But many note that, if systems haven't already started a provider-sponsored plan or had one in the works for about 10 years, that it might be too late to start now, simply because it takes many years for those plans to grow, to reach scale, and the most effective plans have been in the market for 30 plus years. All right, I walked through a lot there around some of those executive conversations. I want to end with just talking a little bit more about what we're seeing in the market right now. So I'll talk about two major things here. First of all, I think we're starting to see a growing divergence over the course of the last year between kind of the haves and the have-nots in MA. What we are starting to see is that United Healthcare is actually performing fairly well on Medicare Advantage. They are, facing some headwinds, but it's not as bad as other plans, whereas Humana and CVS are really struggling right now around MA. And both of those latter two are not going to hit break even this year and are aiming to start a 3 to 4 year journey to get back to hitting target margins of around 4 to 5%, but that they actually think that there might be a new lower baseline around MA profitability. And as a result, their stocks have been really battered in the public market. And I've tried to ask myself, why is there so much difference in this performance between United Healthcare and CVS and Humana, given that they're all kind of facing the same headwinds and pursuing the same strategy? I think part of the reason is that United Healthcare basically is willing to slash other businesses in order to continue funding growth in MA and in order to make a scale play. And so they just slashed, for instance, thousands of employees from Landmark and some of their home infusion businesses in order to not have to reprice plans or in order to not have to exit markets. Conversely, CVS and Humana are both exiting a bunch of markets. And so as a result of all of those shifts, you're about to see United Healthcare likely gain 2% more of the market to the point that they're going to get $13 billion more in annual revenue and have over a third of the entire MA market. But I think it's also United Healthcare's focus on duals and their ability to make a far greater profit margin from the duals population, which McKinsey has said is actually a growing profit pool compared to Medicare Advantage, which is growing much more slowly. The other thing that I think you are starting to see is far greater inability from CMS because of the Chevron decision to likely rein in payer behavior over the course of the next few years. So because of the Chevron doctrine being overturned, what I would expect to see is that it's going to be much harder for CMS to try and rein in payers more than they have over the course of the last years. I would expect the payers are going to continue to contest every single rate cut. And, even things as simple as CMS trying to cut down on incentives for brokers to push certain MA plans are now getting halted by federal courts because of some of the new precedents with Chevron. So I think, right now we're really going to see CMS having their hands tied around future changes for MA, especially around things as consequential as star ratings, which pretty much got entirely rolled back after SCAN and Elevance had brought legal disputes around their star ratings. So really, regardless of who ends up winning the election in November, I think what you're going to start to see is that CMS is going to be far less able to regulate the field and regulate the entire industry around Medicare Advantage. And so what I would look out for in terms of the tea leaves is, does the increase in utilization and unexpected utilization continue for payers? And do they continue to potentially see a new baseline in terms of what now much older seniors are expecting in terms of their care? If so, I think they're going to continue to see some pretty substantial headwinds, and likely, that those headwinds are going to impact Humana and CVS far more because they have this greater exposure to MA in very particular markets where they priced their premiums poorly, as opposed to UHG, which has the same large exposure, but has been a little more strategic about weighing their portfolio of just MA versus duals. If those headwinds continue, I think there's going to be far more egregious behavior on the part of payers to try and continue those prior auths, claims denials, and audits, which is going to likely lead to more terminations and likely more regulatory action being pushed on the part of leading health systems. On the other side of the coin, though, if utilization does start to decrease a little bit, I think you're going to start to see payers start to win some court cases post-Chevron around some of the CMS regulatory landscape, and we might start to see profit margins increase for payers. Overall, it's hard to ever know how bad things truly are for payers. I mean, there's the point where CVS just fired their head of Aetna because they're not performing well, and that's a pretty good sign that things are bad. But I also think there's often kind of a boy who cried wolf type of situation with payers where, for instance, they were already starting to complain about all these headwinds around MA in 2023, and then some Kaiser Family Foundation data just came out that their profit margins were higher for MA in 2023, around $1,982 in gross margin per MA patient, higher than 2022 when it was $1,977 per MA patient. So their gross margins actually grew by $5 over the course of that year, and even grew from 2021. And so I always take those claims of doom and gloom with a little bit of a grain of salt. And I think the real question to see is whether that utilization will continue in terms of making an accurate prediction of how the MA landscape is going to shift over the course of the next few years. So I just walked through a lot there. I'm going to pause at this point and hope that this was helpful just to get your brains thinking about how executives are considering the MA landscape and what to expect over the course of the next few years. Would love to dive into some of these trends a little bit more. If there's interest, can walk through a lot more about the provider-sponsored health plan strategy around MA and how it's been much more challenging than many have expected. Happy to walk through those policy changes as well. So please feel free to reach out to me at jkimmel@hmacademy.com. Would love to continue to hear your thoughts and ideas, and happy to dive any deeper into these topics. Thanks for joining me. Bye. Thank you for joining me on the Health System CXO podcast, where we activate health system leaders towards outcomes and scalable solutions you can implement now. Remember to subscribe to the Health System CXO podcast on your favorite podcast platform so that you never miss an opportunity for insights. If you liked this episode, consider leaving us a review and sharing our podcast with your friends and colleagues. You can also connect with us on LinkedIn by clicking the link in the episode description. See you next time.